Hello everyone, this is Dr. L. Kiran Lakkireddy, working as a consultant interventional cardiologist at Apollo Spectra Hospitals, Amirpet, Hyderabad. Today I am going to brief on what are the services and heart disease managements which I am more expertise with and provide the best care. This is a brief list of conditions. So we'll provide management for medical management for heart attacks, which is called acute coronary syndromes like ST elevation MI, non-ST elevation MI, unstable angina, and chronic stable angina, that is called chronic chest pain syndromes. We also provide evaluation of the chest pain with the test like treadmill test, echocardiogram, and we'll provide medical management of arrhythmias. Arrhythmias are abnormal heart rate and rhythm disorders like slow heart rate or fast heart rates. I am able to provide the best management for arrhythmias. And for heart failure, provide guideline directed medical therapy for heart failure where the heart function is less and presented with difficulty in breathing. We also provide management of hypertension, that is high blood pressure, diabetes, and abnormal cholesterol levels, dyslipidemia. What are the diagnostic procedures which are commonly used in cardiology? One is coronary angiogram, which is a minimally invasive test to identify the heart blocks in the coronary blood vessels, that is blood vessels supplying the heart. Peripheral angiogram is used to diagnose any blocks in the blood vessels supplying any part of the body like hands, legs, and our blood vessels supplying to our bowels, the organs in the stomach, kidneys. It is used to diagnose the blocks in these blood vessels. There is carotid and cerebral angiograms, which is used to diagnose the blocks in the blood vessels supplying blood supply to the brain, which are present in the neck and the brain blood vessels. We will do CATH study for diagnosing heart problems which are present in the birth, like heart holes or any heart valve narrowing, regurgitation, or complex congenital heart diseases. The basic tests you all know which are utilized for diagnosis of heart disorders are ECG, 2D echocardiogram. We also use transesophageal echo for before any interventional planning and diagnosis of any infective vegetations in the heart. Holter monitor test to identify the abnormal rate and rhythm. Treadmill test to identify any ischemia, that is the narrowing of the blood vessels, non-invasive test. What are the scope of interventions? What are the type of what is called an intervention? It is then directed at without opening the heart. We will do some minimally invasive procedures by small punctures in the groin or hand. These are called coronary interventions, like coronary angioplasty, which is called coronary stenting. There are different types of complex procedures, simple procedures in this. One is simple coronary stenting, where you can easily go through the narrowing, keep a balloon and dilate it and keep a stent. One is called bifurcation stenting, where the branches are coming, the disease of the main vessel and branch vessel. Left main vessel stenting, which is the main vessel supplying the heart, nearly 60% of the blood supply to the heart. Chronic total occlusion, which already the coronary blood vessel occluded for more than 3 months, need to open it. It is a very tough situation. We can provide stenting to these occlusions also. We will do primary angioplasty, which is doing in acute heart attacks. Immediately we will do angiogram and stenting. We will do any blood clots are there, you can do thrombosuction. And very calcific lesions, like very hard lesions like cement, these are the very tight lesions to open. We can provide rotablation, orbital atherectomy, or intravascular lithotripsy to provide the better vessel expansion and followed by stenting. And fractional flow reserve or IFR, these are the physiological studies where we do these studies to know whether the intermediate lesions, will call 50 to 70% blocks in the coronary blood vessels. So to identify whether these narrowing are causing symptoms to the patient or not, we will identify through these tests like physiological study called FFR or IFR, and then based on the result of these studies we can proceed for stenting or no need of stenting. We will decide based on this physiological study. This is a very important study to consider when there is an intermediate blocks in the coronary blood vessels. Then intravascular ultrasound or optical coherence tomography, OCT or IVUS, these are the advanced imaging techniques which helps in better analyzing the coronary block and resulting in better stenting results in long term. And for any cardiogenic shock which is very low blood pressure during heart attacks, we will provide IABP impeller ECMO support for this cardiogenic shock. These are some of the examples where I am showing in this is an angiogram where present with acute heart attack, this LAD artery, the artery completely occluded. We passed a wire through this occlusion, is partially open, and we directly stented. This is the stent, and then after stenting, the vessel is opened very nicely. This is another case, similar scenario where acute heart attack, where there is total blockage of the blood vessel. After wiring, we are seeing a faint blood flow. Then we placed a stent. After stenting, the blood flow is very good and the patient done well. This is another case where you are seeing there is a critical stenosis in the branch and the main vessel. This is called like bifurcation stent. This is also RCA, another blood vessel is there. Here we placed a stent. After that, the result is good. This is another case where there is a problem in the branch and the main vessel. We wired both, and then we placed a stent. After stenting, this vessel is good. Then we placed another stent across this. This is called bifurcation stenting, where the coronary blocks are present both in this main vessel branch and side branch. Initially, we placed a stent in the main side branch, and then we are placing in the side branch. And then we will do called kissing balloon dilatation, simultaneous balloon dilatation in the both vessels, and finally we achieve very good result because of these big branches. This is another case. This is called left main trifurcation, where there is a critical stenosis in the main vessel, which supplies the 60% of the heart, and if it closes, all the three vessels will close off. That's very important and very critical lesion here. See 90% block. So we will wire at least 2 to 3 branches here to safeguard all branches. Then we dilate it with a balloon and then slightly more open, and then we place a stent across this, and finally this is a very good result and all the blood vessels are flowing well. This is another case where we are seeing a critical lesion. We wired it and then we opened and we stented. After that, patient achieved better result here. This kissing balloon, and finally achieved very good result. This is like calcific coronaries, where this is the calcium is there, where there is a calcium. This is the calcium where we are seeing is the tight lesion. So this is the rota burr, which is a special equipment to lyse the calcium, like to break the calcium, so that the vessel will expand for ballooning and we can keep a stent, and stent will give a good result. So we are doing rotablation. After that, see how nicely it was expanded compared to the previous result. The same thing, this is also a calcific lesion where is the tight lesion. We have done rotablations, we break the calcium, and after that we achieved a very good result. This is chronic total occlusion, where I already informed it is like more than 3 months occlusion. It is very difficult to open the chronic total occlusion lesions, where we need a lot of wires, balloons, microcatheters. A lot of equipment is required, which is slightly highly cost, some costly procedure. We need to use a lot of material and we need to use different techniques. It takes a lot of time to open these type of blood vessels. So this is a occluded vessel which is more than 3 months. It may be 1 year, 2 years. So after opening, this is the result we achieved. We crossed with wires and microcatheters. We did ballooning, and then this is the stenting we had done. We achieved a very good result. This is another case of chronic total occlusion where the vessel is occluded. We are not seeing anything. We achieved a very good result. This is IVUS image, which is a black and white image. So this is the critical stenosis. Here there are multiple stenosis. So we will analyze from where to stent and what is this plaque, we will call it as atherosclerotic fat plaque characteristics on this IVUS imaging, and we can measure the size of the stent length vessel and the vessel length, and what is the size of the stent length and size length and the size of the stent is required on this image, and we can take a correct sized stent before the stenting, and after stenting we can see whether it is clearly attached to the wall or not. Are there any complications? This will help into detecting and achieving a very good result, where the long-term follow-up, the complications also will be less with this IVUS image guided coronary stenting, which is recommended nowadays, compulsory, in better to use in every case, or at least like proximal lesions or critical lesions. IVUS guided imaging stenting is most preferable. There is another image technology called OCT, where it will give still more clear picture of the plaque characteristics, like which is fibrous plaque, calcific plaque, is the thrombus is present, what type of thrombus is present, calcium, how much calcium, 360 degrees calcium or 180 degrees, what is the depth of the calcium, what it is superficial or depth, everything will get a clear picture on the OCT. This is already stent placed and the patient having again critical lesion, so it is best useful in studying of the instant restenosis where the stent has been blocked, what is the mechanism, and based on that we can modify the treatment strategy for the patient. So after this thing, we dilate it with balloons, and then finally use a drug coated balloon. We avoid the stent by placing another stent. After drug coated balloon, the result is very good. Patient achieved very good result. This is called CHIP PCI, high risk PCI, high risk coronary stenting, where we are doing stenting of the left main bifurcation and two total occlusions here. We opened these LCX and LAD occlusions. In post stenting, we got very good result in both vessels. This is another complex multivessel PCI. We are seeing total occlusion on the right side and same patient having two critical stenosis in the bifurcation. So we achieved good result after stenting in both vessels. This is another case of a complex multivessel PCI where we stented initially on the left side, achieved very good result, and later after 1 month we open the right sided, so it has also achieved good result. We can stage the coronary stenting also whenever there is a complex disease in the coronary blood vessels. With another IVUS guided, image guided ostial LCX stenting where the critical stenosis at the onset. So with the help of this IVUS image guided, you can take a better guidance of where to land the stent proximally and to avoid complications in this area. So we achieved very good result with this IVUS image guided. This is another image guided, IVUS image guided PTCA coronary stents in kidney disease where the creatinine is elevated. So in this case, we had almost used very less amount of contrast, around 10 ml only. Usually for complex coronary stenting, nearly it will take around 100 to 200 ml of contrast. But here with the help of the IVUS image, we used only 10 ml and treated the vessel without giving multiple contrast injections. We achieved a very good result with this IVUS image guided stenting. This is another case of instant restenosis where the coronary stent is blocked. So we opened this vessel in this critical scenario and achieved very good result in this patient. Another set of interventions called peripheral interventions. These includes peripheral balloon angioplasty, that is we open the narrowed blood vessels anywhere in the legs, hands. We open the narrowed blood vessels. It's called peripheral balloon angioplasty by keeping a balloon and dilating the balloon. We can do in the same peripheral blood vessels like in the hands and legs. We can keep stenting. If the result with balloon angioplasty is inadequate, we can stent the narrowed vessel segment. And then is renal artery stenting, where we can stent the renal artery blood vessels supplying the kidneys. If those are narrowed, we can stent these renal arteries. Mesenteric artery stenting, where the blood vessels supplying the bowels, our stomach and bowels, where if it gets narrowed causes significant symptoms, we can stent these also. Mesenteric artery stenting. Then we call coactation stenting. The main blood vessel supplying the blood to the body is called aorta. There is a narrowing in this aorta. We call as coactation of aorta one condition. We can stent even that narrowing. And we call TEVAR and EVAR procedures, which are called endovascular repairs. Particularly useful in case of aortic aneurysms and dissections, which is the main blood vessel supplying the body's aorta, where there may be dilatation of this aorta and there is dissection, cracks in these blood vessels. We have to treat these aortic aneurysms and dissections. We can use without open heart surgery with the EVAR and TEVAR procedures. This is the coactation, where you are seeing the narrowing in the main blood vessel supplying the heart. This is a congenital heart disease, so we kept a stent here and it is nicely opened in the narrowed segment. Called device therapies, where what are these devices called? Temporary pacemaker, where the heart rate is low. we'll keep a temporary pacemaker to support for recovery. If not recovery, then we'll go for permanent pacemaker. There are two types, single and dual chambers, but the most commonly recommended is dual chamber pacemaker in case of very low heart rates, called sinus node dysfunction or complete heart block. And then we'll call it as intracardiac defibrillator. It is called a shock therapy device. We'll implant under the skin and connect to the heart. In case of very high heart rates, called ventricular fibrillation or ventricular tachycardia, we will keep this intracardiac defibrillator where it is automatically detects the high heart rates and give a shock therapy to normalize it. And then we will call it as cardiac resynchronization therapy. This there are specific scenarios in case of like heart failure, particularly when the heart function is very less, like less than 35%, and the patient is having significant symptoms and medical therapy, and ECG we are having left bundle branch block. We can use this cardiac resynchronization therapy for improvement of the heart function. And then we can do electrophysiology study and arrhythmia ablation, where there is having rapid heart rates. We do an electrophysiological study to identify the place and method focus of this high heart rates, and we just ablate with a small current like therapy to cure it. This is called electrophysiological study and arrhythmia ablation. This is the dual chamber pacemaker, where we implant a small device under the skin beneath the left clavicle. Then we connect two leads from this device and placed in the heart. This is called dual chamber pacemaker for low heart rates. So this will pace the heart at normal heart rates. This is the pacemaker. This is the CRT, where we are placing one in RA, RV, and one is the left ventricle coronary sinus we are placing, and it will help in this heart failure. This is CATH study, where we used contrast injections in the heart to identify the disorders in congenital heart diseases. This is here we are seeing the pulmonary stenosis, where the block in the pulmonary connection between the right side lower ventricle and the pulmonary artery. This is the CATH study we will do. We use this CATH study to identify the structural heart abnormalities. Then coming to structural heart interventions, we'll do balloon valvotomies like BMV, BAV, BPV, device closures of the heart holes like ASD, VSD, PDA, coronary cameral fistula, paravalvular leak, and then the newer interventions like TAVI or TAVR, transcatheter aortic valve replacement, trick valve, left atrial appendage closure. What is balloon valvotomy? We can open the narrowed walls between the two chambers in the heart and the walls between the blood vessels and the heart. Mitral valve, aortic valve, pulmonary valve, and tricuspid valve. We can open those narrowed walls by keeping a balloon across the wall. These are called balloon valvotomies, mitral, aortic, and pulmonary. This is balloon mitral valvotomy, where we are keeping a wall balloon across the across the mitral wall, which is the connection between left atrium and ventricle, and we will dilate and open the narrowed wall. This is balloon mitral valvotomy. We will enter the left side of the heart from the right side, and then we will place a balloon and we will get across the mitral valve, and then we inflate the valve and open the narrowed valve. This is balloon mitral valvotomy, and this is balloon aortic valvotomy, where the valve connection between the left ventricle and the aorta, which is the main blood vessel supplying the body, we open with like balloon aortic valvotomy. And this is balloon pulmonary valvotomy, the connection between the right ventricle and the pulmonary artery, where the valve is narrowed. Then we open that valve with balloon pulmonary valvotomy. This is called balloon valvotomy. And then device closures of the congenital acyanotic congenital heart disease, which are the holes across the two chambers in the heart and two blood vessels, is called ASD and PDA and VSD. This is the ASD device closure. This is the PDA, where there is a connection between the aorta and the pulmonary artery, two major blood vessels. We are keeping a small device across this, and the device will be sealed off. And this is the ASD device closure, where the hole is connection between the two upper chambers of the heart. We place the device like this and we close the hole. This is VSD, where there is a connection between the two lower chambers of the heart, and we will place the device across the hole and we will seal off that hole with this small plug. This VSD device closure. Other interventions, we can use IVC filter, where there is a thrombus formation in the heavy thrombus formation in the veins of the legs, there may be chance of those migrating to the main pulmonary blood vessels, that is blood vessels supplying the heart, having a very high risk. So in this case of very high thrombus burden in the legs, we will keep in the IVUS filter to prevent this thrombus migration. Then we will do carotid stenting, where we will place a stent in the neck vessel narrowing, which supplies the blood to the brain. When there is a critical stenosis, we can keep a carotid stent and open that narrowing. This transarterial chemoembolization in some carcinomas like liver carcinomas, we can deliver the drugs therapy through the blood vessels to the preferred site. Then we can close any abnormal bleeding from the blood vessels inside our body. We can stop that bleeding by keeping a coil, or we can keeping a gel foam, like particularly in uterine artery bleeding, where there is heavy bleeding postpartum or from the uterus blood vessels, and the bronchial bleeding, which is causing hemoptysis, that is blood in the coughing. So we can close those leaking blood vessels. And then we can do catheter-induced thrombolysis, that is called where there is a blood clot in the blood vessels, like in the lower legs and the upper limbs, or the venous in the venous segment of the venous or arterial segment in the limbs, or in the pulmonary embolism. We can keep a catheter to the localized clot where there is a blood clot. You can take a catheter and then we can infuse the injections, thrombolytic agents, through that catheter in that specific site, so that it helps in the resolution of the blood clot. These are the few conditions, like acute lower limb ischemia, where there is a blood clots in the legs, in the arteries, iliofemoral DVT, blood clots in the veins in the legs, pulmonary embolism is the blood clot in the blood vessels supplying the lungs. You can do aspiration thrombectomy in pulmonary embolism by specific catheters, where there is heavy thrombus burden in the blood vessels supplying the lungs. You can use either angiojet or penumbra device to aspirate the thrombus and clear the thrombus. These are the interventions provided by me in these critical scenarios. So right now I am working in Apollo Spectra Hospital, Amirpet, Hyderabad, as a independent consultant interventional cardiologist. I already discussed what are the expertise I am in and providing the best results in all types of complex interventions, cardiac and coronary interventions. So you can contact this number for any appointment and for the best treatment. Thank you very much for your patience.